Next, we'll move on to factors associated with limb occlusion in the long term after endovascular aortic repair by Janae Rice.
Yes. Good evening, everyone. My name is Jane Rice. I'm one of the Penn Vascular Surgery residents. I'll be presenting on factors associated with limb occlusion in the long term after endovascular aortic repair. So graft limb occlusion is a common complication after EVAR repair, studies citing as high as 7.6% in their cohorts. Patients may be asymptomatic and might be incidentally found on surveillance imaging, but most patients present with symptoms of claudication and most concerning signs of limb ischemia requiring urgent treatment with the risk of lower extremity amputations. Limb occlusions may present in the perioperative period, but as you can see in this graph, most likely to occur in the long-term follow-up. So the aim of our study was to investigate rates of EVAR limb occlusion in the long-term follow-up. We looked at the VQI endovascular AAA registry, examining their procedural and their long-term follow-up data sets over about a 10-year period. We looked at sociodemographic and comorbidities before the index surgery, along with index operative factors. And then we compared limbs, the limbs that were occluded in the long-term follow-up versus non-occluded limbs. We did bivariant log rank tests and stepwise multivariant Cox analysis. For definitions, long-term limb occlusion was defined by the VQI as an occluded graft limb found on follow-up imaging. So we only included patients with follow-up imaging. This only included aneurysms with infrarenal extent, and we excluded patients with just aorta grafts or patients that would, of course, converted to open surgery. So looking at first, we captured about 33,000 EVARs performed at 65,000 limbs evaluated. 498 limbs were found to be occluded in the long-term follow-up, about 0.79%. Mean follow-up for the data set was around 453 days. But for first occlusion, for patients that did have a limb occlusion, the first occlusion was found in a mean follow-up of about 390 days. Looking at our univariate analysis, you can see our Kaplan-Meier curves here. Black patients, patients on Medicaid, patients who smoked preoperatively or on dialysis had higher rates of limb occlusion in the long term. And we also found that patients with prior PAD surgery and prior EVAR surgery prior to the index surgery had higher rates of limb occlusion in the long term. Looking at operative factors, patients undergoing repair for rupture had higher rates of limb occlusion in the long term. We also found that patients who required a cut down for access, need for femoral adjuncts such as endarterectomy or repair, along with the need of iliac adjuncts for delivery of the sheath device, such as ballooning or stenting, had higher rates of long-term limb occlusion. Most interestingly, the iliac endpoint in the external arteries was associated with long-term limb occlusion, having greater than one iliac limb used, along with coiling and covering of the internal artery were associated with long-term limb occlusion. Looking at our multivariate Cox regression, this found that internal iliac being covered or coiled had the highest association of limb occlusion, followed by prior PAD surgery, urgent repair, multiple iliac grafts being used, perioperative smoking, open access, and then suprarenal aortic fixation grafts. So overall, this analysis of a national multi-center data set found, that patient factors such as smoking, prior PAD surgery were associated with limb occlusion in the long term, and then certain operative and anatomical factors such as coiling and covering of the internal iliac artery and the use of multiple iliac limbs were associated with higher limb rates in the limb occlusion. And I think the use of multiple iliac limbs is probably the most significant for me. If we have a good endpoint in the, mid-common iliac, I have some of my attendings that will actually use a second graft to extend right at the bifurcation. So that may be putting those patients at higher risk. So that may influence my practice patterns in the future. So ultimately, patients with these risk factors after EVAR may benefit from more frequent surveillance, along with patient education for symptoms to be aware of, such as new onset claudication, before more limb-threatening events occur. And then patients with these risk factors may benefit from earlier interventions to maintain assisted primary patency. However, further investigation is needed. Thank you.
Just real quick, did you look at graft type or manufacturer? I know the VQI captures that.
Yeah, we did not with this analysis, just, not wanting to.
Did he take y'all's questions? Everybody looked disappointed there.
No.
Dr. Lee's still standing.
Yeah, no, I wanted to say that I think that looking at this is an important way to figure out different subtle differences between different manufacturers. And, obviously, despite each of the main manufacturers being here supporting us, I think having a data set like this, we could really learn about, certain anatomies and certain types of devices. So I'd encourage you to, since you have access to the data, to really figure out which ones had sort of issue. And then my bias has always been the smaller limbs probably sort of occlude more, meaning even both the external iliac and sometimes doing a cut down as a marker rather than doing it percutaneously. So those are some things for the paper that I'd want to see sort of subtly teased out, but nice job.
Thank you.
Dr. Lau, did you come up with something?
Yeah, I did. Very nice presentation, Jane. It's always good to see someone explore this again. I was curious, and I don't know exactly all the elements within the VQI data set for EVAR, but distal aortic diameter and cracking that, as we do often now, as opposed to using AUI, could be a risk factor too. Is that something that you were able to look into?
So it didn't capture, those more nuanced, anatomical or operative things, but we actually didn't find a difference between the diameter of the endpoint in our, analyzing this data set.
And our last question?
Yeah, hi, Ted Gifford. Nice talk. Did you guys, your time to interval event was like a little over a year or so. Did you look in a time-dependent fashion to see whether or not the rate of limb occlusion is going down over time? Now we always say, oh, we have better technology, we have lithotripsy angioplasty, we have iliac branch devices, maybe now our limb patency is going to be better. I'm curious whether or not you could see that.
Yeah, that might be something we can do for the next paper, for the paper.
Sorry, just a fast comment. I think
just
everybody.
No.
Please.
Okay.
Just to comment on everybody's thinking about endograft, and I think everybody in this room knows that the endograft behave differently in the iliac limbs. And from the VQI, I think you should try to push and try to see if you can get device identification. Because if there's a certain device that have double or triple the rate, I think that would be an important signal.
Yeah, I agree.
Excellent work.
Thank you.
All right, let's move on.